Okay, so we're going to talk about seizures, disorders. A seizure represents an abrupt and transient occurrence of signs or symptoms resulting from an abnormal excessive discharge from neurons in the brain. The term convulsion actually refers to a motor seizure involving the entire body. Usually the first seizure episode occurs before the age of 20, and after 20 years of age, a seizure is caused most often by structural change like trauma, tumor, stroke, things like that. You can have provoked or unprovoked seizures. Provoked seizures almost always occur due to serious illness or injuries that affect the brain, infections. There's always something going on that causes the seizure to happen. In an unprovoked seizure, this unprovoked seizure usually occurs for no identifiable cause. It's kind of just out of nowhere it happens. A provoked seizure, an example would be a febrile seizure, which is more common in our ages 6 months to 5 years of age. Febrile seizures are one type of provoked seizure, but in order for it to be a febrile seizure, there can be no other evidence of a central nervous system infection or a metabolic disorder. So it has to just be this unexplained fever and causing this this seizure to occur. So that would be provoked. Unprovoked seizures are like those that we see in epilepsy, which is characterized by epilepsy as recurrent seizures that are not provoked by other illnesses or circumstances. And one of the things that we have to do is differentiate between a focal seizure and a generalized seizure. And focal seizures are those type of seizures that begin in a specific or a focal area of one cerebral hemisphere. And generalized seizures are those that begin simultaneously in both hemispheres. Focal seizures are the most common type of seizure among newly diagnosed epilepsy. The most common type of seizure in young children is generalized seizures. This is something that we see when we talk about your grand mal seizure, your tonic-clonic, absent seizures, and things like that. These generalized seizures have varying degrees of symmetric movements. They may happen without evidence to localization in a hemisphere. They include being some degree of unconsciousness, and the person doesn't really know that it's even going on at the time. What we'll see with seizures is that they'll have an aura, which is that sensory warning sign that they get of impending seizure activity. So they kind of stop whatever they're doing, and you can kind of see them glance off. They have this aura that happens. So they may taste, see, hear, smell something that kind of warns them of an impending seizure. Basically, we have tonic-clonic seizures. We have tonic seizure by itself, a clonic seizure by itself. You can have absent seizures, and you have to be able to kind of differentiate these. So basically what happens in a tonic seizure, if it was just by itself, the tonic, we think of tone or muscle tone. These people, they get really stiff and straight. It's a sharp tonic contraction of the muscles with extension of the extremities and immediate loss of consciousness. In the clonic seizure, you'll see rhythmic bilateral contractions and relaxation of the extremities, and then they remain unconscious until that RAS begins to function again. And that could be anywhere from hours, it could be minutes to hours, actually, however long that they're in that unconscious stage. And that unconscious stage following a seizure is called the postictal state. So that's when they remain unconscious afterward. What you see up here at the top is a tonic-clonic seizure, and this is where both of these are occurring together. So the patient will have a combination of the two, and I'm going to show you a video. So he's starting to have the seizure. And now that's the tonic phase. So he's extended. His muscles are fully contracted. He's extended. You can see he's in this tonic phase. Now he begins to have the clonic phase where he's having the bilateral rhythmic movements. And you can see that evidenced in the video. That's that clonic phase. And so then the next thing I want to show you is the absent seizure, because when we see absent seizures, I can't talk today. This is a generalized type of seizure that occurs, and we see this in children a lot of time. It used to be called a petit mal seizure, and it'll kind of visualizing it and watching it'll kind of give you an idea of what's going on.
You're on a long video, honey. I can see you. That's William. Haley, what's up? Haley, what's up? Haley, what are you doing? Thank you, William. That's for sharing. Got it? Yeah, they're sharing. Let's go with Fox. Drawing pictures here. What's your favorite thing to draw? You like to draw parties?
So that's just an example of an absent seizure and what happens during that type of seizure. The last term that you see is status epilepticus. Basically, that's when somebody doesn't come out of the seizure on their own or spontaneously, or they have multiple seizures back to back, and it's really not good on the brain and it causes damage. It's extremely important to note the time and the onset and the duration of the seizure. 60 to 90 seconds is a typical seizure. What you see on her head is called an electroencephalogram. Electroencephalogram. Sorry, I can't talk. And it's an EEG for short, and it determines the brain waves and the electrical impulses or activities that's going on in the brain. And that's the most useful diagnosis that we have for seizures. Now we'll talk about neurocognitive disorders. It's important that you understand that when we talk about neurocognitive disorders, these disorders involve changes in a spectrum of the memory and cognitive functions. Memory is the ability of your body, of you, to process or encode information, store it, and retrieve it. And that's it. That's why we say, don't memorize when you get into class. Cognition is the part of the brain that you need to use in order to understand the material and process and condense it, elaborate, transform it, and use it. And so what we see in neurocognitive disorders is that these people lose the ability of both of these. Generally, we see the disorder usually aging over 65, it starts to really progress. It's a very slow progressive disease. in familiar forms of Alzheimer's disease, they indicate there's an accumulation of something called a amyloid beta peptide that initiates a change of events in the morphology of the brain itself. So they'll have this accumulation of this amyloid beta peptide. An accumulation, like I said, of that peptide causes a buildup of changes in the morphology of the brain. What we also see is deficiency in choline acetyltransferase, which prevents the synthesis of acetylcholine. And the acetylcholine is a neurotransmitter that we need in order for memory to occur. So we see that they are deficient or have a decreased level of choline acetyltransferase or acetylcholine. So they would have low levels of acetylcholine. And we need those for memory. A hallmark symptom of Alzheimer's disease. First, we have short-term memory loss, and then denial. They'll try to act like I didn't mean to do that. I just seen if you would catch it, or I was just kidding. They start to realize that this is happening, and there's nothing they can do about it. So they have memory loss, and then denial, and then they'll progress to, in the second phase, if you will, they'll progress where they get confused and disoriented and impaired abstract thinking. They'll have personality changes. They forget where they had placed important things. They get lost easily. They have trouble remembering appointments and common things. Depression is often one of the personality changes that occur. They'll get very depressed as they realize that this is happening. The changes are progressive to the point of losing the ability to respond to the environment. They become incontinent. They can't speak. They forget to eat. Sometimes they forget to swallow and move. Death is definitely a possible complication due to chronic debilitation. And so in severe Alzheimer's disease, those changes that you see that where they lose the ability to respond to the environment, that's more of the most severe case. But this is kind of how the disease progresses. The neurodegenerative disease called Huntington disease, we talked about it briefly, or you had a little activity on it during the genetic section. It is an inherited autosomal dominant disorder with an onset of about 30 to 40 years of age. The problem is that it does not present until the 30s or 40s, and so people have already had children and possibly passed it on down to their children by that time. And it's a chronic progressive disease characterized by chronic progressive chorea and physical changes and dementia. There's localized death of brain cells, and the first and most severely affected cells are those of the basal ganglia, and that's what actually modulates our motor neurons, or motor output. So what we say is they have chorea or choreiform movements. There is no cure for Huntington disease, which is very sad, and I'm going to show you a video of Huntington's disease and so you can see what they look like.
Anything makes it hard for me to watch. Killing me. Because of HD, my brother has to shake. Hello, my name is Daniel Hunting. I'm diagnosed in 97. And I have a daughter whose name is Caleb, who is at risk, which means she has a 50-50 chance of getting.
So I think if you can see that, you got a little bit of idea of what Huntington's looks like, and it's definitely something that's very debilitating for people, and it's very hard. The movements that you were seeing are uncontrollable, involuntary movements that we describe as chorea or choreiform movements. They usually have a lot of spasticity, like you can see in that video. So that sums up Huntington disease.